session is going to be on fetal echo. Uh, Fetal echo is something
Hello.
which I picked up. Hello, fetal echo uh, has been into practice to a significant extent in the last couple of years, and it has made tremendous progress in terms of technology and its implications. So, as a pediatrician, it's important for us to understand in general just the basics of fetal echo. So what we will see today is just indications. I'm not even going to include the role or the use of fetal echo in today's session. Now, indications of fetal echo would include two things. When would you consider and whom would you consider to get a fetal echo done? Now, it's important for us to understand why do we do a fetal echo? Do we really need a fetal echo? Second is the timing of fetal echo. What is the ideal time when to do a fetal echo? Third is on whom to do a fetal echo. That means the real indications for fetal echo. And at the end of it, what is the yield of fetal echo? Yield of fetal echo in the sense that if you do fetal echo in 5 cases and one case came positive in terms of detection of a congenital heart disease, then it's 20% yield. And then the last is whether should we do fetal echo in our country as a targeted approach, that means to do it only in high risk mothers, versus to use it as a screening test for every single pregnant women. Now, first, before we start understanding the role of fetal echo, we need to understand that the incidence of congenital heart disease now, it's considered to be based on the latest information available. The prevalence of congenital heart disease is 9 in 1,000 live births. This is including even minor heart diseases like bicuspid aortic valve and small muscular VSDs. Amongst this, 25% of the congenital heart diseases are considered to be critical. Critical means what? The child needs intervention in the first 1 year of life. And this congenital heart disease incidence is actually much higher compared to the chromosomal anomaly incidence and the neural tube defects. It's much higher. That means the burden is huge. Overall, it accounts for 30% of the neonatal deaths due to congenital defects, and it also accounts for 10% of infant mortality. And so we cannot neglect that the burden of congenital heart disease is huge, and we have to understand that it's not going to be easy to pick up these babies at birth, because a normal examination of the newborn, it does not exclude a heart disease. Why is it like that? Because babies have, as we understand, the ductus arteriosus, which can keep the baby completely stable for the first 3 days or even couple of days initially. So by the time the baby goes home after delivery, the baby starts having symptoms. So it is understood that 25% of the babies with these complex congenital heart diseases go home undiagnosed. And the saturations could be more than 90%. The low volume pulses could be well felt. So as a pediatrician or a neonatologist, it gets extremely difficult to pick these up clinically, and we do not consider echocardiography in every single child. Though we have the guidelines for measuring the saturations, the pulse oximetry saturations after 48 or 72 hours, we may not be able to pick up all these complex congenital heart disease, and there comes the role of fetal echo. If we can pick them up in fetal life, then we could reduce this number of newborns who go home without diagnosis. And if we do a fetal echo, what happens finally? Now, it is known that for diseases like VSDs or even, for example, tetralogy of Fallot, it may not make any difference in long-term outcome. However, it does help reducing the perinatal mortality for situations which are critical, like ductal dependent systemic circulation, like coarctation or hypoplastic left heart, or when you have failure of mixing, like transposition, or you have a ductal dependent pulmonary circulation like pulmonary atresia or critical pulmonary stenosis, and in arrhythmias. So remember, these are the 4 subset of children where if you diagnose it prenatally, it can make a difference, because you're going to work on lots of things during pregnancy, at delivery and after delivery, so that you have a child who is managed in an ideal way. So the role of fetal echo. Now with this understanding, let's see, when do we ideally do a fetal echo? Remember that the motion of fetal heart can be seen as early as 6 weeks of gestation. So by the time she knows she is pregnant, the motion of the heart can be observed, but the structural analysis is possible usually by 15-16 weeks. And 18 to 24 weeks, the imaging of the heart is satisfactorily done. But after 24 weeks, because we have calcification of the ribs and the spine, and the amount of fluid becomes lesser, the movement of the baby becomes lesser, the fetal echo windows would be limited. So ideally, any time in second trimester would be an ideal time to do a fetal echo. However, we need to know that 20 weeks is the legal age of termination in our country. And hence, we do fetal echoes before 20 weeks. So anytime between 16 to 20 weeks is an ideal time for doing fetal echo in our country. There are times where we might have to do it a little early, and this is called the first trimester fetal echo, which is done as early as 12, 13, 14 weeks. And we do this only in situations where we have high risk mothers, where, for example, if the first baby had hypoplastic left heart, then we do consider a first trimester fetal echo. How do we do it? It can be done trans-vaginally or trans-abdominally with a high frequency linear transducers. Fetal echo is done with a transducer which is different compared to a cardiac probe, and it's considered to be a curvy linear probe. And the thing is that if we do a fetal echo in the first trimester, we need to repeat the imaging before 20 weeks the second time. This is sort of done just to make sure that we have a good four-chambered heart, the great arteries are crossing each other, and the two AV valves and the cellular valves are okay. For precise understanding of the fetal heart, we need to repeat the imaging. The common indications based on the nuchal translucency scans would include some amount of tricuspid regurgitation or an abnormal ductus venosus Doppler. If we have these two, then we need to do the first trimester fetal echo scan because these are strong indicators for the fetus having chromosomal abnormalities. So this is very few situations where we would consider the first trimester fetal echo, but in general, we would do it between 16 and 20 weeks of gestation. So as a pediatric cardiologist, we usually consider the trans-abdominal. The fetal medicine specialists, they do a first trimester scan. They would use a combination of transvaginal and trans-abdominal scans. Now, there are times where we would repeat the fetal echo. So what are those conditions where we would consider repeating the fetal echo in spite of it being done by around 20 weeks of gestation? For example, if the baby has arrhythmias, even if the baby has an ectopic atrial activity, we need to repeat it, and there are guidelines how frequently should we repeat. For example, if it's an ectopic atrial rhythm, which is occasionally seen once in 2 to 4 weeks, we would repeat a fetal echo. Versus if the child has a well-developed supraventricular tachycardia and you start treating, then once in 72 hours, we need to monitor the baby. The second would be if the mother has autoimmune disease. If the mother has autoimmune disease, the baby can have conduction disturbances, and it's important to monitor this throughout pregnancy, especially till 34 weeks of gestation, because the damage due to transplacental transfer of antibodies can happen till 34 weeks of pregnancy. And in this situation, we monitor them very closely. Usually once in a week, monitoring is needed to document the PR interval, to pick up the first degree heart block so that if it's there, you could treat it and you could prevent development of a complete heart block. If you have aortic valve or pulmonary valve stenosis, remember that this stenosis can progress and become critical or can become complete atresia. So if you have aortic stenosis, it can become aortic atresia. If you have pulmonary stenosis, it can become pulmonary atresia. So you need to monitor these valves throughout pregnancy. If you have an atrioventricular valve regurgitation, for example, mitral regurgitation, which is moderate, then you need to monitor because it can become severe and develop hydrops. And then the last is if you have ventricular disproportion. Normally the right side of the fetal heart is dominant compared to the left. So usually the right and the left measurements, if we take, both should be equal, or right should be a shade bigger than the left up to the ratio of 1.2:1. If this ratio is not maintained because of some reason, then you could be dealing with an abnormal left or an abnormal right heart. And in that situation, in borderline situations, you would want to monitor because things could change as the pregnancy proceeds. So during gestation, the growth of the ventricle needs to be monitored. So these are the situations where you would consider repeat imaging. Now, there are indications for fetal echo which are well published by different bodies, and they get modified, and these are the latest indications for fetal echo. So these indications, you could divide them into maternal causes, fetal causes, or familial causes.
Sir. Thank you.
Maternal causes, for example, if the mother has illnesses like diabetes mellitus, systemic lupus erythematosus, or Sjogren's syndrome, so any of the autoimmune diseases, or rarely phenylketonuria. Or if the mother has been exposed to certain infections, like it could be rubella, toxoplasmosis, or the mother is taking medications like typically anticonvulsants or antidepressants, or if the mother herself has a congenital heart disease, and if it is in vitro fertilization, if it's assisted reproductive techniques used for conception, then fetal echo is indicated. So all IVF babies, we need to do a fetal echo. Fetal indications would include what? Abnormal cardiac screen. That means when a fetal medicine specialist or a radiologist is doing an anomaly scan by 20 weeks, and if they notice that the heart does not look normal, that is defined as an abnormal cardiac screen, then a detailed fetal echo is needed. Increased nuchal translucency. We will see a little more in detail, more than what and at what age does it have an implication. If a extracardiac anomaly or a chromosomal anomaly is picked up in the baby, then it's an indication for doing the cardiac examination. If there are situations where we know that the fetus is having a risk of developing congestive heart failure, or the baby already has hydrops fetalis. Monochorionic twinning or twin gestation for that matter, if any fetal arrhythmia is picked up, and if there is polyhydramnios. So these are the fetal indications for fetal echocardiography. And then there are certain familial indications. For example, if the father has or the previous baby has or had a congenital heart disease, or if there is a family history of either syndromes or a single gene defects. Now we are going to see a little about these indications in detail. Now, family history of congenital heart disease. So it's important for us to get this history. Is the mother had a heart disease? Did the father have a heart disease? Or did the previous baby have a heart disease? Sometimes the previous fetus would have been aborted who was diagnosed to have a heart disease. So this history is important for us to elicit. What is the recurrence risk? If one baby had a heart disease, then the expected chances of second baby to have a heart disease is 2%. This is how much more than the general population? This is actually 10 times more. The general incidence is, for example, 5 in 1,000, and this is 2 in 100. So it's on an average 10 times more than what the first baby had a chance of having a CHD. Now, there are families where you would see two babies, for example, atrial septal defect, which is familial, atrioventricular septal defect sometimes is familial. Then the chance of third baby having a heart disease is up to 10%. Now, this understanding about recurrence risk is very important for us because normally one baby with a heart disease, the parents have a lot of apprehension to plan for a second child. And in that situation, it's important for us to say that though this incidence is 10% of general population, 10 times of general population, still you have more than 95% chances of having a baby without a heart disease. So it's not something where they cannot plan for a second child. So when you do a fetal echo in this situation and you tell the couple that the baby is normal, that reassurance is very invaluable for the couple. Remember that this percentage, when we talk about, it's not for individual heart disease, this is in general. There are heart diseases where we have the recurrence risk, which is much higher. The recurrence risk is found to be much higher for the second child for left-sided heart lesions and complex congenital heart diseases like single ventricle and truncus. If it's aortic atresia or coarctation, you can have up to 7% chances of second baby having a heart disease. And if it's complex heart diseases, truncus arteriosus or heterotaxis, it can go up to 10%. So the counseling needs to happen in that way, and hence early trimester fetal echo is indicated in parents who have the first child with complex congenital heart disease or left-sided heart lesions. The second we will see now, there are families who have inherited disorders of single gene defects. For example, Ellis-Van Creveld syndrome or Marfan syndrome or Noonan syndrome or Williams syndrome, Holt-Oram syndrome, tuberous sclerosis or DiGeorge. So if the first baby has been diagnosed to have any of these, then it's an indication for doing a fetal echo. There are subtle signs which you could pick up in the first baby. For example, cleft palate, cleft lip, hypertelorism, bulbous nose, low set ears. See this bulbous nose here. This is Williams, where you have a typical long philtrum. So there are a few things which you could pick up in the first baby in case the baby is not being diagnosed or approved. And then consider fetal echo for the second pregnancy. There are certain metabolic disorders, the most commonest being diabetes mellitus. Now, diabetes mellitus, it has a 3 to 5 times increased risk of a congenital heart disease compared to normal population. However, this risk is much higher. Amrita, I think some other centers have been put on, you need to mute them. There's a lot of sound coming from other centers. So, it's important for us to monitor the blood sugar levels and also HbA1c. However, if the values are higher in the periconceptional period, then it's going to be high risk. If somebody develops diabetes in the second trimester, then it's not going to increase the risk of developing congenital heart disease. Overall, the yield of diabetes mellitus is on the lesser side. Only up to maximum 7% of these babies have congenital heart disease. If this develops later in pregnancy, then there are chances that we might have myocardial hypertrophy. So left and right ventricular hypertrophy is known to happen, especially if the levels of blood sugar are not well controlled in the third trimester. But that is something which is reversible over the couple of few months after delivery. Autoimmune diseases like systemic lupus erythematosus and Sjogren's disease can affect the conduction system in terms of variable degrees of heart block, and these antibodies typically they are the anti-Rho and anti-La antibodies which can cross the placenta at around 16 to 18 weeks. Apart from causing conduction disturbances, it can also cause cardiomyopathies. Most of these mothers are asymptomatic. So most of the times we really don't know if the mother has it unless and until the first baby has a heart block, and then you evaluate the mother and you realize that the mother was actually carrying those antibodies. So these mothers need a fetal echo in the subsequent pregnancy. So it's not that these autoimmune diseases cause only effect on the conduction. They can also cause myocardial damage. Now, exposure to drugs or viral infection. So typically there are few drugs which the mother takes, then the baby can have a congenital heart disease. It includes phenytoin, lithium, paroxetine, certain NSAIDs including ibuprofen, and retinoids which is used for acne, and certain viral infections like Coxsackie, parvovirus, or any of the torch infections. And this also does not only cause a structural heart disease, but it can typically cause myocardial involvement also. Coming to nuchal translucency. Nuchal translucency, if it's more than 3.5 millimeters, then the prevalence of congenital heart disease is higher. So if it's more than 3.5 millimeters, but these measurements need to be taken surrounding 14, 15, 16 weeks of gestation. It can't be taken later in gestation. It has no significance then. 23% of pickup rates in this fetuses is there if the nuchal translucency is higher. So even if these babies do not have a chromosomal problem, they have a direct pickup of congenital heart disease. So measurement of nuchal translucency more than 3.5 millimeters is an indication for fetal echo. What about extracardiac anomalies? Actually, the overall risk is very high. If a renal anomaly is picked up, then 50% of these babies will have a cardiac problem. And if a CNS malformation is picked up, then 5% of these babies can have a heart disease. So the pickup is very, very high. The yield is very, very high. The common extracardiac anomalies which are picked up in fetal life and then they turn out to have a heart disease, the most important would include omphalocele. That's a midline defect. Omphalocele, exomphalos major or minor, typically is associated with a ventricular septal defect and a tetralogy of Fallot. Also, duodenal atresia, which is commonly seen in Down syndrome or in isolation, can have a heart disease. Diaphragmatic hernia, tracheoesophageal fistula, polyhydramnios, and single umbilical artery. These are important indications for doing a fetal echo. Single umbilical artery can have multiple repercussions, but 40% of these babies will have an abnormal heart. If an anomaly scan, they have picked up situs inversus, all the organs are in the opposite direction, then we need to make sure what's happening to the heart. Typically, in a total situs inversus, the heart could be normal and it is dextrocardia mirror image. So these are few extracardiac anomalies where we strongly need to think about doing a fetal echo. Chromosomal anomalies. So if a chromosomal abnormality is picked up, then 50% of these babies will have a congenital heart disease. The typical chromosomal abnormalities which get picked up are trisomy 20, 13, 18, and then a 22q11 deletion. These are the ones which have a strong association with CHD. Now on the other side, if a CHD is picked up, 10% of these babies have chromosomal abnormalities, but again, it also depends upon the type of CHD which is picked up. For example, for an AVSD, we have the association of chromosomal abnormalities very high, and even the extracardiac anomalies very high. 50% of children with AVSDs have abnormal chromosomes. Whereas for diseases like transposition or even corrected transposition of great arteries, the possibility of chromosomal abnormality is very, very little. Most of our babies with CTGA have no associated non-cardiac problems. Now, there are certain conditions which are known to cause fetal heart failure, and they include a vascular tumor or an AV malformation. These are the situations where you have hyperkinetic circulation, because of which fetal heart failure is known to happen. Or there could be situations like absence of ductus venosus, where the baby can go into cardiac failure and hence a fetal echo is indicated. Arrhythmias is not that uncommon. 1 to 2% of all pregnancies have some abnormality in the rhythm, amongst which the most commonest is just irregularly irregular rhythm, which could be ectopics. And then you can have tachyarrhythmias, and then you can have bradyarrhythmias. So there are three types of abnormal rhythms which can be picked up. And if you have an abnormal rhythm, the possibility of having a heart disease is in the range of 10 to 15%. If you have this combination of a heart disease with a heart block, then your risk of having intrauterine demise is high. The possibility of having a structural heart disease is more with bradyarrhythmias than with tachyarrhythmias and extrasystoles. With bradyarrhythmias, 40% of fetuses have a structural heart disease, whereas with, for example, SVTs, very few fetuses will have a structural heart disease. The common structural heart diseases which we want to rule out with an arrhythmia is, for example, Epstein's anomaly or corrected transposition or atrioventricular septal defect, or sometimes cardiac tumors or even myocarditis. The atrioventricular septal effect with heart block, there is 96% in utero mortality. So if you have this combination of heart block with atrioventricular septal defect, then the prognosis is really poor. Once we have picked up arrhythmias, then it helps us monitoring, treating through maternal therapy and improving the prognosis of the fetus. Now, in general, remember that echogenic focus initially used to be one of the indications for doing a fetal echo. However, echogenic focus in isolation, the yield is very low. Yield means this is what a little study which I did it, and we realized that the pickup rate of a heart disease is very, very little. Compared to that, if you see that abnormal cardiac screen, if a gynecologist thinks that the heart is abnormal in an anomaly scan and then refers, the yield is very high. 2/3 of these children had abnormal heart. So the maximum yield is in situations where they pick up abnormality in the anomaly scan or familial causes. If the mother has a CHD, if the previous child has a chromosomal abnormality, etc. Cardiac abnormality was detected in 20% overall, but the highest yield was in abnormal cardiac screen. In general, the global literature says that the pickup of CHD happens in up to 20% cases which are referred for fetal echo. And they also say that the abnormal cardiac screening views has the maximum yield, and then comes the fetal non-cardiac abnormalities like extracardiac or chromosomal abnormalities. The yield is minimum in situations where you have maternal diabetes or advanced maternal age or isolated echogenic focus or single umbilical artery. So these are the situations where your pickup rate is not that high. Now, one thing we need to understand that we consider doing a fetal echo in indications which we so far understood. So these are considered to be high risk group mothers. Now, if we do high risk group mothers fetal echoes very religiously, then we are going to pick up only 10% of actual cases of congenital heart disease. So this is a big paradox in front of us. So if we can pick up only 10 to 20% of CHDs, if we strictly follow this protocol, the rest 80% happen actually in non-high risk group mothers. So then the question comes, should we do fetal echo as a screening tool for all the pregnancies? And as we understand, then we have the question about technical expertise. Do we have the time? Do we have the access? And do we have the financial support of doing fetal echoes for every single pregnant woman? So with that understanding, the whole thought process comes down to the fact that it's not practical for us to pick up this way. And if we stick to high risk mothers, we're going to only pick up 10 to 20% of congenital heart disease. So in that situation, we need to understand that screening ultrasound is the most effective tool to pick up fetuses that would benefit from a fetal echo. That means if you pick up an abnormal cardiac screen in an anomaly scan, then it's going to help us to pick up many congenital heart disease because the yield is high. So the whole idea is now to train the gynecologists, radiologists, and the fetal medicine specialists who are routinely performing anomaly scan in every single pregnant woman to teach them how to pick up an abnormal heart. And hence, now we have shifted the focus from the basic scan to an extended basic scan. Basic scan means what? It's just the four-chamber heart alone. Initially, the person who does the anomaly scan was supposed to pick only a four-chambered heart and make sure that the four-chambered heart is normal. This was the basic scan. Now, this basic scan would pick up 60% of the congenital heart diseases. Now, the focus has been on the extended basic scan, where apart from a four-chambered heart, they also need to include the outflow tracts, the left and the right. And this is known to pick up 90% of the congenital heart diseases. So this is a more practical way of progressing further, where during anomaly scan, the person is supposed to do an extended basic scan, pick up an abnormal heart, and then refer it for fetal echo. I think this is the take-home message today. And this is the end of our session today on indications of fetal echo. Feel free to ask any questions. The uses and the role of fetal echo, we will have to go individually by the views and we will talk about it. But in general, I can summarize for all of you for today's session that fetal echo is done for ruling out major heart problems which are complex and need multiple surgeries or may not be curative in nature. Fetal echo is not done to rule out small cardiac problems like ventricular septal defects or treatable lesions. We have to understand that atrial septal defect and ductus arteriosus, both of which are physiological in fetal life, will close after birth. Whether they will close or not, we cannot predict in fetal life. There is only 10% of the cardiac output going into the pulmonary veins. If there is pulmonary vein, one single pulmonary vein abnormality, we cannot pick that up in fetal life. Coronary abnormalities, we cannot pick them up. Small muscular VSDs are easy to miss in fetal life. So these are few limitations of fetal echo. So we will end our session today. Feel free to ask if you have any questions.
Hello.
Any questions or clarifications?
Good morning, madam. Thanks for the presentation. And my doubt is regarding the urinary tract infection in relation with the cardiac abnormalities. Suppose if any urinary infection in the first trimester, is there any chance of getting congenital heart diseases for that type of?
No, not to my knowledge. Urinary tract infection, usually bacterial in nature. I don't, I haven't come across any correlation with a congenital heart disease. No. Okay, I have a question here. Lethal heart disease indicating medical termination of pregnancy. So I understand that your question is basically when would you want to terminate pregnancy is your question, correct? Now remember that our topic today was exactly opposite to the question which we have today, but I understand your curiosity that when is it that we explain the parents about termination. So remember there are heart diseases which we would split into three different varieties. There are heart diseases which are simple. For example, if it's a ventricular septal defect or a suspected coarctation, I would put them as simple because most of them will require a single staged procedure. And after that, uh, for example, in a VSD, the life is like a normal life. On the other end of the spectrum, you have diseases which are very complex and not curative. For example, hypoplastic right heart or hypoplastic left heart, where you need multiple surgeries which are palliative in nature. And then there are heart diseases which are somewhere in between. For example, tetralogy of Fallot. Tetralogy of Fallot is considered somewhere in between because it has been realized that by third or fourth decade of life, you have the morbidity and mortality picking up. So it's nowhere close to a normal life. So in this situation, the counseling happens based on the understanding about the disease, the long-term prognosis. But remember, every baby is different. So you can have a tetralogy where you have a life which is completely normal. So every child needs to be individualized, and in general, practice is that you never outrightly direct the parents for a decision to do what, but you are there to explain to them what happens to the baby on long-term basis. In general, my approach has been that if it's a single ventricle, I might tell them that I would respect the decision if they consider termination, because single ventricle, even in today's life, is not that easy to manage for a family. Versus there are parents who ask for termination for an aberrant right subclavian, where you will put your foot down and explain and re-explain and counsel and recounsel and spend a lot of time with them to support them to continue pregnancy. I hope that answers your question, but I think that is something which we will take it sometime later if you're interested. Any more questions? Ideal timing for fetal echo, I think we discussed that. The ideal timing for fetal echo, I think in our country, I would put it as 16 to 20 weeks. 16 to 20 weeks of gestation, we need to see the fetus before 20 weeks, because 20 weeks is the legal age for termination. Any more questions?
Hello.
Amrit, yes.
Hello, Dr. Ajit from Calicut.
Yeah, tell me.
I just wanted to know how you do that. How do you look for arrhythmias in fetus? Your talk was excellent.
Can you just specify your question? What do we do in arrhythmias, in the sense you want to?
How do you detect the arrhythmias? How do you in the fetus?
So primarily it is suspected just in general when the anomaly scan is done and they realize that the heartbeat is irregular, or it is very fast, or it is very slow. So there are ways to suspect, but once you suspect, then you further analyze using your M mode and Doppler technique. So we do not have facilities to do ECG in fetal life. So we do Dopplers and also M mode. There are two techniques on echo which we use to specifically understand what type of arrhythmia are we suspecting. And we can fairly come to a closer understanding of the type of arrhythmia. For example, if it's a supraventricular, we can sort of suspect the type of supraventricular arrhythmia. And if it's bradycardia also, we can sort of suspect whether it's a sinus brady or it's a complete heart block, or is it a atrial ectopic which is blocked, sort of an understanding to further then plan out the management. Would you advise termination for hypoplastic left heart? So again, I would tell you that I never ever dictate the parents, because I feel the decision is very, very personal. I have had couples who have continued pregnancy in single ventricle because that's what gives them satisfaction. So I would definitely give them a very clear picture of what are the probabilities most likely going to happen to babies, and then leave the decision to them. But I agree, I would respect their decision of termination if they consider termination for a hypoplastic left heart.
Any more questions? Thank you, ma'am, for the wonderful session.
Okay, thank you so much, Amrita. Thank you all for your interaction. Thank you so much. Have a nice day.